not going to be controversial. I'll just tell you what I've seen around the world. Like, and there's another great moment for me today, which is the man who just walked in the room, James Barrow, over there, is Google Glassing this conference. So it's the first time I actually saw Google Glass. And then he said he's going to email it to me.
Yes.
So, thanks for that. Okay. Before I start, I just want to say that we are in truly the greatest industry in the world at the most unbelievable time to be in this industry in the world. So I have traveled literally many, many times. We had 150 countries in our network. I spent a lot of time, about 30 of them. And there is no other industry that is going to produce as much gain in human productivity than this industry. And the proxy for human productivity, as you all know, is wealth. Wealth creation is about human productivity. And we are really at the right industry at the right time, and a bunch of wonderful things are happening all over the world. So I am an eternal optimist about this industry. We're all in the right place, and we're all going to make a few little mistakes here and there. But the truth is that science is behind us, and demographics are behind us. And because of that, we're going to have, everybody in this room, a tremendous opportunity for unparalleled impact around the world, both in our own communities and what we import and export in terms of knowledge, and ultimately human well-being. And I think that that's fantastic. And I tell this to everybody. So I am not a skeptic, and I'm not somebody who worries that much about the cost curve, because the cost curve is going to come down. We'll talk about that in a minute. I'm a huge optimist. So this is, even though I might say some controversial things, it's in a backdrop of the truth is we're in a great industry, and we are moving the ball ahead everywhere. So when I first took the job as the global leader for PwC, I had this point of view that mostly in the U.S. we were the best at what we do, and that we had problems that were different. So 4 years later, what I learned was, first, is that most problems are the same all over the world. 75% of the problems, I would say, are the same. Everybody's dealing with aging in developed societies, and in emerging economies like China, both aging and rising demand. And then in emerging economies, you're dealing with rising demand. And so the issue is, how do you give more and more and more to people who need more and more, who either want to pay for it or who are getting older, yet in the face of a tremendous dynamic where there's not enough supply. Now here in the U.S., we would argue that there is oversupply of some parts of the system, but like the Health Minister of Norway once told me, we had him in a panel, he said today about 20% of the labor force here is in the healthcare services business. And if we look at the way we are aging, and if we take care of everybody the same way we take care of them now, in 20 years, 2/3 of the workforce is going to be in healthcare, which is never happened. So we have to understand that in the macro, we're looking at a dramatic increase in requirements, and the way we provide care is going to have to be completely different. So what I learned around the world, and listening to all the folks that I met, with hundreds of CEOs, and we had a global branding effort called Bending the Cost Curve. We take best cases from all over the world and show them. I'm a big believer that every time I had a really brilliant idea, I just have to look around the world that somebody's done it before. So why not learn from others? And what I came to understand is that there are 3 macro trends that I will assert that are going on around the world. And I really do believe in keeping things stupid, and so if I can keep it stupid, keeping things simple, stupid, if you know that expression. And in the end, when I talk about healthcare, I try and really keep it simple. The 3 trends that we're seeing, and I'm going to go through them individually, are first, there's a huge change in dialogue between the public sector and the private sector. I've never seen any leader of a health enterprise from the private sector said we can do this without the public sector. And I've never seen a health minister say that we can't do this anymore alone. Now, I'll get into the details of that in a minute, but it's an important thing to understand as we face what we've been facing now over the past 2 years, and what we're going to face in the next 10 years is with the Obamacare, with the ACA, about how the dialogue has changed. And it's not unique to this country. The second big trend is finally our sector is industrializing. And there are two groups of people in the world, I've found. One group says that healthcare is so messed up and so confused and so fragmented, it's never going to look like every other sector. Then there's the other group, which I'm a believer in. Healthcare is finally going to straighten itself out, and it will industrialize like every other sector. And we'll talk about that. The third big trend, in my view, is the health sector, is finally becoming a precision-based sector. And we'll talk about how that starts with understanding truly the pathophysiology of illness and where innovation comes from, in genomics and the like. But we'll then move and think about how we're moving from a population-based set of services and understanding about disease to what it really means to be a precision-based sector. And that has deep implications across the labor force, has deep implications around research and discovery, and frankly is probably the most important vector for bringing down costs. So let's start with the first one. New public-private sector dialogue. Well, governments in general have given up the notion that they're the best at innovation, efficiency, and customer service. But where governments really believe that they have an important part to play, and I would subscribe to this notion, is around the issues of quality and access to healthcare. The private sector likes a level playing field, and in fact likes to exert themselves around efficiency and innovation as well as customer service. And so in those regards, what we see around the world are new kinds of models of care where financial processes, customer service are all being aligned by new kinds of contractual arrangements between the public and private sectors. We see this in developing countries. We've seen some fantastic new public-private partnerships in places like Spain flourishing, whereby the government conveys an asset, which is the right to collect and distribute fees, reimbursement, in exchange for contracting with the private sector. So in places like Spain, when there's new hospitals, basically the government will say, okay, they'll bid out for this community, we're going to build a 200-bed hospital, but we just don't want the private sector to build a hospital. We want the private sector to take responsibility for the entire range of services. Emergency room, immunization, outcomes, the whole kit and caboodle. These things are flourishing all over the world. We see them in developing, and even underdeveloped, and new kinds of economies. We saw this in Africa, a place called Lesotho, where the actual infrastructure is miserable. Highest maternal mortality in the world, new kinds of public-private sector dialogue, brought in a private sector company from South Africa, built a brand new hospital, aligned the incentives. Within 6 months, maternal mortality went from the worst in the world to in the top quartile. So aligning incentives, getting the public sector and the private sector to work together is a new phenomenon. And we're seeing new dialogue wherever healthcare is a huge issue. And frankly, I'd say that healthcare is not top of mind in some economies, but in most it is. So here's the question for you all. What is the biggest public-private partnership, probably in the world, that comes out of the United States? Say it again.
Medicare.
Medicare, not just Medicare. Medicare Advantage is the biggest public-private partnership in the world. Why is that? The asset that the federal government has is the right to reimburse. That's transferred to the private sector in exchange for obligations. When you look at the Medicare Advantage program, what you're really seeing is the federal government contracting with the private sector to provide a set of services that it otherwise would have provided, but allowing them to innovate on those services. So when we think about some of the stuff that's going on here, the truth of the matter is it's going on elsewhere. It's going on here, it's going on all over the world, and this is going to continue. And I think it's really positive because when you look at, really, in the end, who ultimately is going to be able to provide efficiency, effectiveness, and innovation, it's going to be ultimately the private sector. So we really get on board, and we encourage these kinds of discussions. We encourage the private sector, a wide variety of countries, to sit down and have good conversations with the public sector. Ultimately, that's where success lies. Second big trend, industrialization of the sector. So let's think about this for a minute. When you look at the rest of the economy through the 70s and 80s, we've seen massive gains of productivity and wealth creation through enterprise, and it's all through IT. It's through enterprise technology. It's through understanding processes in major organizations. And today, and in the past 10 years, today, we've also seen dramatic transformation in other sectors of business models related to personal technology. Well, healthcare has been really slow, as we all know, in both those arenas. With respect to hospitals and enterprises, we've been slow to catch up. And certainly, with respect to personal technologies, slow. Well, as the rest of the sectors have struggled and have improved themselves to the process improvements over the past 30 years, now they've got the new personal technology revolution. Healthcare is double trouble. We've got both of these things happening at the same time. So what does it mean when we think about enterprise technology? How does that change an industry? Well, Simon asked me to talk about this example. One of the best examples I've seen is the kind of notion, I'm sure some of you are familiar with Regina Hertzinger's work on focus factories. Well, there are focus factories around the world who are really starting to produce care at unbelievable efficiency and quality. So the great example I use is my friend Debbie Shetty in India, who produces more heart surgery probably than any one single place in the world, certainly in pediatrics. 2,500 cases a year, tetralogies, neonates with very severe heart disease. You walk into his operation, he's got 84 NICU beds lined up, 12 by 7 rows. He produces better quality care than anyone in the world. And in fact, if anybody had, God forbid, a child that had a severe cardiac anomaly that required surgery, the best thing they probably could do for that child is to take him to Bangalore in India and get that child operated there. The fee for that surgery is $2,000. And every year, he thinks about how to make it 10% less. And it's because he has broken down every single process about what that surgery is about. And in fact, he's got this big elephant with paintbrush, a picture in his room. He said, I could teach an elephant how to do heart surgery. Elephants know how to paint. I didn't know that. They know how to paint their own reflection. He said, if you understand the processes, you know how to do that. And I didn't really believe him that much. I thought, the labor is low, the labor costs are low, et cetera, et cetera. So we sent him a physician. Actually, I'm trying to understand what was going on. Just to give you an example about process improvement, how long, for those of you who know, does it take to pre-op an infant here in New York or New Jersey for a neonate for a major cardiac surgery? When I mean pre-op, from the crib into the OR and ready to start the surgery. Somebody want to throw out the number? How long? 2 hours. 2 hours, 2.5 hours. But we went and timed those things in Bangalore, India. 12 minutes. 12 minutes. Think about that. At the National University in Taiwan, where I think it's the only level 7 level 7 installation, I asked the person who's charged, chief medical officer, tell me about your medication error rates. And he said, well, we don't really measure them anymore. So I said, what do you mean you don't measure them anymore? He said, well, they've been so far below 1% for so long, it's not even something that we think about. Because they have a complete closed-loop system in Asia, many hospitals, that it's impossible, unless you're trying to commit fraud, to give a patient wrong medication. We bring those error rates down to 0. And people here in the U.S. say to me, well, oh my gosh, I don't know what the standard here is, but when you look at some of the organizations, they say, well, the standard is 5% or 10%, and the nosocomial infection rates or this, that, and the other thing. And you can get down to zero rates. And it's not surprising because in other industries that have industrialized, they get these Airbus 380s off the ground with 600 people in them. That is way more complicated than, in fact, trying to produce 0 medication errors in a hospital. And yes, we can do it. I was invited last month to the Commonwealth Fund. David Blumenthal participated in innovation. And just to kind of stir the pot a little, he said, what's the most innovative thing that we can do in America? I said, well, I think we should post the daily pills at every hospital. So he said, talking about Atul Gawande was there in the room and was telling me, He said, wait, I said, just post them, and they'll go away. Because the truth of the matter is we know how to eliminate errors in all other sectors. And when this sector gets industrialized and we understand the supply chain, they will be eliminated. And we think about paying for outcomes in the way we're all, well, we pay for outcomes because doctors know what they're doing and nobody can figure out what they're doing. Well, the truth of the matter is there is an alternate theory that as the sector industrializes, when we know the value chain, you don't have to pay for outcomes. You just have to pay for things that create value and don't pay for things that don't create value. And so this whole idea about what you pay for and how you align incentives and get people to do what they're supposed to do, people who are in the supply chain business really understand exactly how to get value, not by an outcome, but by understanding every piece. And then you look at the personal technologies arena. And for those of you who haven't read this book, I think it's a classic. You should read Clay Christensen's The Innovator's Prescription. And when you think about the transformation of business models that we see today in other sectors, oh my gosh, why would we ever think that healthcare is going to be different? It's crazy to assume that it's different. At a very high level, think about, and he says this well, at the beginning of all sectors, what happens is that the problems migrate to the solutions. But as sectors mature, solutions migrate to the problems. Everybody understand what I'm saying? So in the beginning of the IT world, IT industry, way back, IBM had this huge mainframe thing. And then they went to minis, then we went to laptops, and now we have mobile, right? And so the solutions are migrating towards the customer's problem. Somebody needs to explain to me how that is any different in healthcare. And we start from a hospital, and then we move to an outpatient, and then we move to a retail clinic, maybe, and then we move to the home. It is absolutely normal. Every sector on earth historically has behaved that way. And there's no reason to assume that healthcare will behave any differently. And as I think about that, and I think about these issues about doctors owning, hospitals owning doctors, and all this kind of stuff, it's kind of illogical to me. Because in the end, what we are really doing and where the sector is going is trying to understand exactly what contributes value. Yesterday, does anybody know what luggage forward is? It's a company. I'm taking my grandchildren skiing. So now, I always skis and stuff. So I call them up, luggage forward, send your skis. Because you have to pay by plane. So I'm talking on the phone with this guy, and I'm saying, I got these skis, and he says, well, our logistics carrier is going to handle it. I said, who's your logistics carrier? He said, well, it's UPS or FedEx. So I said, well, can you then explain to me why I'm talking to you? He said, well, one is I'm going to follow this for you, and I'm going to give you a level of customer service so that you're going to have total confidence that when you show up, your stuff is going to be there. More than the airlines, and better than UPS and FedEx, because I have a layer of customer service. So the logistics is outsourced. Think about that in the hospital arena. Think about the logistics. Once we understand them, they're not going to be the value contributor. It's ultimately going to be the customer service. That wins in the end. And we're going to get there. 5 more minutes. Last one. Precision-based industry. This is a really interesting topic. I'm of the belief that when I see all of the talk about innovation in healthcare, mobile devices, this, that, enterprise technologies, that's not really innovation. That's basically following what all the other sectors have done. The real innovators in technology are the guys who founded Oracle, Larry Ellison, and Steve Jobs, who figured out all these platforms. Those guys are innovators in their field, and all of these other people piled on as the business models have changed. That's not, it may be innovative in a way in the sector, but what the real innovative elements in healthcare are is about human physiology and human biology. When you cure HIV, when you cure infectious disease, when you cure cancer, when we have these therapies that are coming through new research that really can fundamentally change the way we engage and the way we live, that's innovation. And the innovation that's unique to the healthcare industry is deeply related to devices and deeply related to physiology. I was at the MIT Media Lab about 3 or 4 months ago. Anybody been there? Know what I'm talking about? MIT Media? Unbelievable place. So they do all that 25 labs, leading edge things. They have a prosthetic lab that is incredible, that is really reinventing the way people use prosthetics, particularly amputees. And you see all the people, the runners and marathons and this and that. And that's where innovation occurs. It doesn't occur in other service areas. When you go to some of the labs and you see some of the sequencers and the DNA and the things that are being produced and the rethinking about what human disease is about, and the fact that we're finally understanding the two cancers that we thought were different cancers are more related around certain pathophysiologic and genomic elements, then we're really starting to understand and then apply therapies in a much more focused way. So when I say precision-based, we have lived in an industry up till now, and this is really around genomics. It's a population-based industry. We measure things based on population. We don't measure them based on individuals, and we don't measure them based on physiology. We are now coming to understand that breast cancer is not one disease, it's probably 15 diseases. And when you look at the way Big Pharma has traditionally looked at interventions, huge trials, huge cost, lots of years, lots of patient months, but it's really trying to find out those big blockbuster drugs for a whole pool of patients are going to raise the therapy value in the aggregate. Now, I'm an epidemiologist, so I like to think in epidemiologic terms. Precision really is around the sensitivity and the specificity, namely the false positives and the true negatives, but it also is highly dependent on the prevalence of illness. So when you want to do a test on somebody, you want to make sure that they are the ones that really have the condition, and in fact, that the application of a therapy or diagnostic to that particular individual is going to be spot on. Well, that's when we move to precision. And that, historically, has dramatically altered cost. So let's look at an example of that. When I was a young practicing physician here in Bergen County, yes, I practiced in New Jersey, I was at Stafford Valley Hospital for many years. I, as an epidemiologist, had a deep interest in, then we called it AIDS, we didn't know it was HIV. But when those patients came to see me, the referral pattern was to a subspecialist in immunology for infectious disease. Diagnosis, treatment, cost was spectacularly high. Spectacularly high. With the understanding and with the precision-based diagnostics for HIV and the tools and the discoveries, the truth is the identification and treatment of HIV has dropped dramatically. And not only has it dropped dramatically, but the people who take care of it have changed completely. HIV around the world is not taken care of by physicians. HIV is mostly diagnosed and taken care of by nurses and nurse practitioners all over the world. And so not only does science change the way we approach and we treat, but it has deep implications for the scope of practice. So an example I use a lot is in the 1920s in New York City, who used to inspect elevators? Engineers. Who inspects elevators today in New York City? They ain't engineers. So in general, as industries mature, specialization increases at the very edge. But everything else for which we can't establish precision and rule-based intervention, everything gets pushed down more and more and more to lower education and lower skill bases. And that is the natural course. And so one of the things that create a lot of controversy, I was in South Africa, and I got a lot of people upset, as I said, I don't understand the whole thing about primary care physicians. It makes no sense to me. Why do we need more primary care physicians? Why would you invest so much money to put somebody through medical school to be a primary care physician, having been one, at least 90% of the stuff that I used to do was at least as well done by nurses and nurse practitioners than what I was trained to do. And by the way, like the Minister of Health of Norway said, are we really going to have 2/3 of the labor force in the next 20 or 30 years taking care of patients the way we take care of them today? Absolutely not. And so I'm a big believer that when we think today, primary care panels have 2,500 patients per panel per physician, the real issue is, how do we get that from 2,500 to 25,000? How can a single primary care physician have a view of 25,000 people, not 2,500? How do you make that 1x to 10x? Now, it's going to happen because necessity is the mother of invention. It can't otherwise not happen. Because you can't build enough medical schools in the next 30 years to train enough doctors to possibly get to a situation where you can have primary care physicians taking care of all the people who are going to get old and need services the way they get old today. There'll be innovations, obviously, in medical. But the truth is, it ain't going to work this way. So as we move to a precision-based industry, lots of fabulous things are happening. Not only will things like Alzheimer's get cured, in my view, not only will we understand cancer, not only will we going to live longer, to 100, and all those kinds of things, but the way that we think about the scope of practice is going to change. The way the healthcare labor force is going to roll out is going to be much different than it is today. And if I were in a planning situation, I would think about those issues, and I wouldn't say that healthcare is different. I'd look at other sectors and say, what's really happened to the other sectors? And how have they adjusted? How have they morphed themselves to render better service, or I call faster, better, cheaper, but in a completely different way? So those three things, pretty much on time here. Those three things, think about new public-private sector dialogue, healthcare sector industrializing, and we're moving into a precision-based industry. Those three things are what, after traveling around the world for 4 years for PwC, those are things I learned that everybody has in common. And if I could leave you with a thought, and that is that we don't do everything the best here in the U.S. I have seen almost everything done better somewhere else, maybe not in the aggregate, and I'm not saying that other health systems are better. Do not get me wrong, although systems in general perform better, as you all know that we do here. There's a lot to learn from outside of our frontiers. And in pursuing the way this industry will roll out, cost will naturally fall out. And I say to all the people who worry so much about costs, I said, I don't really care if 10% of the GDP, or 15% of the GDP, or 20% of the GDP. That's not what really matters as it relates to healthcare and the costs. Don't think of healthcare as a cost problem. Think of how we move the industry along to take away steps, because that's what we all want to do. But in the end, for every increment of cost in the healthcare system, as long as you can match or increase that increment in human productivity, you ought to keep on investing and investing and investing and investing. Because in the end, it's not what it costs, but it's the productivity, human productivity and longevity, productive longevity, that comes from those innovations and those interventions is what really counts. So we have to look not at the P&L, not at the income statement of healthcare. We've got to look at the balance sheet. And when we think about the balance sheet, the real issue in the end is not what it costs, but actually it's what we get, and how fulfilling the lives we lead, and how long we live, and how, now I'm pushing 60, how much longer I can continue to be a triathlete. I'd love to go to 100, well, maybe 70, 80, or something like that. So that's the way I think we should be thinking about the problem. So that concludes what I was going to say, and I'm happy to take a few questions. I hope I didn't stir the pot too much.
Hi, I'm a PwC alum as well, and to ask if you've ever studied Sorry, my name is Jerry O'Connor, and I'm with a manufacturing company here in northern New Jersey. I'm originally from Ireland. I studied industrial research in college, and I'd just like to ask how many of you have had a look at the theory of constraints in industrial research. A lot of it came out of World War II, but a lot of what we've applied in manufacturing has come out of World War II when lives were on the line. And the supply lines were basically maintained and response times were improved through two key theories. One was the theory of constraints, and the number one person expert in that area was Ellie Goldratt, who wrote the goals and regaining competitiveness in some other areas. And that basically teaches you how to take care of bottlenecks, because when you attack the bottlenecks in the 2 hour, trying to get from 2 hours down to 12 minutes, it teaches you how to do so. The second one was the transportation model, and that was how to eliminate slack in in various models within the hospital. Just wanted to know if any of you have any, if you have had a look at those two particular models.
So, I'm not an expert in those industrial models.
Sure.
And there's a whole lot of work still yet in the hospital system, particularly, that can be followed as it relates to those to paradigms of thought and intervention. But the thing that really struck me about people who are really taking it up a level are, like Levy and others, is probably akin to what Toyota did in revolutionizing the assembly of the object, which was not a linear type of revolution. It was kind of thinking about the problem differently. So I would say that maybe you could get it thinking linearly. You could probably get that pre-op from 2 hours to an hour. But to get it to 12 minutes, the way those doctors work is completely different. The way they swarm that patient, and you have actually the specialist doing the only thing that only that specialist does over and over and over again in a setting that gives them the ability, that enables them to do that. And then when you go to the NICU, the way the nurses work in the NICU are completely different. The way they team and the way they swarm patients, how they move from problem to problem to problem to problem. I said to Debbie, I said, what's your nosocomial infection rate? How much hospital infections do you have here? He said, we have 0 MRSA. 0. They have an NICU with 84 beds, and they have 0 MRSA. 0. So that's more than an industrial, that's more than, I think that's supply chain. That's rethinking the problem, I think, in a completely different way.
Well, actually, with respect, I would say that when you get into how the inspection departments and the quality issues are investigated, and in specialized engineering firms, I think it's a very similar process. My wife is in the medical profession, and she just completed the Six Sigma process with the Nobel. And I'm just seeing a lot of the same stuff rehashed. I mean, put it in a much nicer format, but a lot of the elements have already been identified, in my opinion, and it's a question of. I understand that there's a need to make it a lot less harsh than the manufacturing, but a lot of things have already been identified, in my opinion.
Just to conclude on that, I would just challenge people in this room right now, today. Why is it that we have what we have? Why is it that we have these nosocomial infections? Why is it that we have vaccines? And I believe it's because we tolerate it. There is no reason why this should exist. None. It's all about leadership. And it's all about making sure that everybody understands that we should have 0 tolerance for these kinds of things. If you can get an A380 up off the ground, you can have 0 MRSA and 0 accidents in the hospital. And if anybody thinks that I'm crazy, you can raise your hand. Oh, that's one.
I'm a doc in practice. I think you're missing the massive feature of this paradigm, which is making an A380 is a profitable venture. Delivering healthcare is not.
And I can imagine there's probably a number
right? There's a huge difference there. Making an A380 is mechanical, its specifications, its tolerances. Healthcare is human, and intrahuman things are subject to foibles. But worse than that, you make money and you build an A380. In healthcare, it's highly likely you'll make less money next year than this year. So there's this massive economic incentive. And by the way, I don't want to give you a hard time. I think you are right on the money, David. Absolutely right on the money. The paradigm of how we deliver care, matching task to the right level of provider, you're absolutely right. But there is a big impediment there, so I don't think it's a fair comparison.
Yeah, and unfortunately, we are human, and we got to deal with the time frame right now, and a lot of folks probably have.
And I'll be happy to talk about this another time.
Thank you.
Thank you. Hold on.
Before I let David go, there's one thing. Happy birthday. Today. One of them, he typically does not accept to give presentations. He did this as a personal favor, and then I find out on top of it, it's his birthday. So I really wanted to thank him for his thoughts. And I I understand Dan's comment. Dan's also a good friend, but I think this is one of the biggest debates that David and I experienced when we were traveling the globe is where is the line between healthcare being a social right versus an economy? And that's another conversation that will consume a lot of wine and a lot of time. So just before I get the conference moving, there's a lot of seats in the front. So if you want to move forward and take a seat,
Stop recording.
Please go ahead. And let me now introduce the